Hello, everyone, and welcome to the Radiology Cardiothoracic Imaging podcast. My name is Sonny Abbara, and I'm the editor-in-chief of the journal Radiology Cardiothoracic Imaging. The host of our podcast is Praveen Ranganath from Dallas, Texas.
Hey, Dr. Abbara. Hello, everyone.
Hi, Praveen. In this series of podcasts, we will break down recent articles and trending topics from the journal through conversations with the authors, the editors, and experts in the field. For all of you out there interested in cardiothoracic imaging, subscribe and listen to the podcast to keep up to date with recent developments in cardiothoracic imaging.
Make plans to join us at RSNA 2020. Virtually connect with colleagues and industry partners, explore RSNA's first ever digital exhibition floor and AI showcase, and access more than 350 hours of the latest science and education from every subspecialty. All RSNA members get free premium access to RSNA 2020. This includes CME opportunities, on-demand programming, and extended access to meeting content through April 2021. Register now at rsna.org/annual-meeting.
Hello, everyone, and welcome back to the Radiology Cardiothoracic Imaging Journal podcast. On today's episode, I'm joined by the senior author of a recently published paper in the October-November issue of the journal. The paper is titled Diastolic and Systolic Cardiac Dysfunction in Pectus Excavatum, Relationship with Exercise and Malformation Severity. This paper comes to us from our colleagues in Buenos Aires in Argentina. The first author is Dr. Ignacio Raggio, and the senior author is Dr. Gaston Rodríguez-Granillo. First, let's discuss a bit of background. Pectus excavatum, or pectus excavatum, is a chest wall malformation that results in more than just aesthetic alterations. Some potential symptoms include exercise intolerance. Exercise intolerance in these patients is thought to be multifactorial in etiology, and cardiopulmonary derangements likely contribute to symptomatology. Although it is hypothesized that extrinsic compression of the right ventricle may contribute to some symptoms, few robust studies characterizing this effect have been performed to date. Regarding therapy, surgical correction is the mainstay in these patients with well-documented improvement in symptoms and quality of life. The authors of the featured paper practice at a very high-volume chest wall surgery center in Argentina. Stress echocardiography and chest CT are standard parts of the diagnostic workup for pectus deformities at their center. The featured paper is the largest study to date on stress echo manifestations of pectus deformities. They evaluated 269 patients with pectus excavatum that were part of a prospective registry that ran between August 2012 and May 2018. The investigators also recruited 35 normal controls who underwent stress echoes for comparison. Now, let's briefly discuss the results. With exercise, patients with pectus achieved fewer METs than normals, about 8.2 versus 11.8. Pectus patients demonstrated more RV function derangements compared to normals. Some of these derangement parameters include RV systolic and diastolic function, tricuspid area increase during exercise, tricuspid annular plane systolic excursion, or TAPSE, tricuspid systolic wave, and RV malformation indices. While the differences for these parameters were all statistically significant between pectus and normals, the absolute differences were somewhat small. I'll refer the readers to the paper for the specifics on those numbers. Lastly, at a median follow-up of about 3-ish years, 33% of patients underwent corrective surgery. Despite all of the stress echo parameters measured, the only metrics predictive of surgery were younger age and correction index, which is a CT-derived measurement similar to the well-known Haller index. Overall, this is a well-conducted study that sheds light on the often overlooked cardiac consequences of pectus excavatum. To explore further the details and clinical impact of this study, I had the privilege of talking with the paper's lead author, Dr. Gaston Rodríguez-Granillo. Let's dive into that conversation now. Right, listeners, welcome back. I have the pleasure of having on with me senior author of our featured paper, Dr. Gaston Rodríguez-Granillo from Buenos Aires in Argentina. Gaston, thank you so much for coming on to the podcast. How are you doing?
Thank you very much, Praveen. Thanks for having me. It's a pleasure and a privilege to be able to be here with you and discuss our study.
Yeah, hey, the privilege is all ours. Thank you so much for joining. Let's first learn a little bit about you, Gaston. Can you tell us more about yourself? Where are you from? Where are you working currently? And how did you get involved in the current study?
Yeah, my name is Gaston Rodríguez-Granillo. My current position is Associate Director of Cardiovascular Imaging at Instituto Médico Neri, Clínica La Sagrada Familia in Buenos Aires, Argentina. And although this paper we're going to discuss, this observational study was done at Fundación Hospitalaria Children's Hospital, Clínica Olivos, and Diagnóstico Maipú, that are also, of course, in Buenos Aires. This study, in brief, is a result of a close and very productive multidisciplinary collaboration between the pediatric chest wall surgeons, being Marcelo Martínez Ferro, the real brain behind the whole concept, Dr. Ignacio Raggio as the lead cardiac echo expert and first author, and a large number of radiologists and cardiologists.
Wonderful. Thank you so much to everyone that was involved in the study, including yourself, our senior author. Let's jump into the paper now. As a reminder to our listeners, the paper is titled Diastolic and Systolic Cardiac Dysfunction in Pectus Excavatum, Relationship with Exercise and Malformation Severity. So, Gaston, beyond the aesthetics of pectus deformities, can you describe to us the potential cardiopulmonary consequences of these malformations? You describe some of them in your paper. Obviously, we know that these consequences can bear a significant morbidity on this patient population. So talk to us about why these cardiopulmonary consequences occur, focusing on the right ventricular dysfunction.
Yeah, the underlying mechanisms responsible for the cardiopulmonary consequences that can be found in these patients are clearly multifactorial and hardly related to a single aspect. Indeed, as we previously discussed briefly, in few patients we see very severe findings. Basically, we see multifactorial findings involving several aspects. These patients can have simultaneously completely different cardiopulmonary findings that can also be deeply interrelated. Some of these findings include pulmonary aspects such as impaired respiratory biomechanics. For example, they typically have abdominal breathing, or they have inability to achieve deep inspiration, and can have also a restricted pulmonary function, and several cardiac findings such as systolic or diastolic dysfunction, ventricular dysynchrony, that's something that we want to study in the near future. Rhythm abnormalities, it has been described that many of these patients suffer especially palpitations, but can be found atrial fibrillation, and some of them can have pericardial effusion. A number of considerations need to be made, basically. Firstly, each of these patients, we have learned from the chest wall surgeons that each of these patients is absolutely unique, with a completely original and different malformation phenotype, including differences in the depth of the depression, the symmetry or asymmetry of the depression, the site of maximal depression, and different behavior throughout the respiratory cycle that can affect the cardiovascular system and the lungs in a completely different way. Also, the assessment of symptoms or limitations in this patient is difficult, since on one hand, these individuals have spent most of their lives with these limitations, and on the other hand, it might also be the case that some physiological adaptations have taken place through the years, such as increased peripheral oxygen uptake or increased heart rate. And basically, this is the other question you told me is what are the main findings in the right ventricular? Yes, there are several previous studies have explored the effect of pectus on the cardiopulmonary function, involving in general small populations of a lot of different countries. And I think one of the largest of these populations was a series from Dr. Dawn Jaroszewski from Phoenix. She involved 170 patients who underwent intraoperative transesophageal echo. Actually, many of these papers have explored right ventricular function in this fashion. And these studies have explored the effect of Pectus using a variety of approaches, including echocardiography, using either with or without strain, and also some studies including intraoperative transesophageal echo or follow-up imaging, such as one of the original studies from Poland in 1999. Also, some smaller studies, including one study of our own, have explored the effect of Pectus using MRI. One of these studies from Switzerland, from USCAN, identified 44% of right ventricular systolic dysfunction using MR. We have not confirmed such finding in our own previous smaller population, but overall, although most of these studies were quite small, in general, they have demonstrated improvement in right ventricular systolic volume and strain during surgical repair.
Excellent. That was a great review of the relationship between pectus deformities and cardiopulmonary consequences. Now, with regards to your study is very unique in that it is the largest one to date, exploring the potential impact of these pectus deformities on right ventricular dysfunction. You recruited 269 patients with pectus excavatum, all of whom underwent a chest CT and stress echocardiography. From what I understand, these tests are part of the standard pre-op workup at your institution. Also, you recruited 35 additional age-matched control patients who underwent stress echo for comparison. Could you talk to us about what data points you collected from both the CT scans as well as from the stress echoes on these patients?
Yes. Patients who attend the Pectus Clinic, located at the Fundación Hospitalaria Children's Hospital, are deemed in general potentially, and who are deemed potentially eligible for conservative, that sometimes is the case with the use of vacuum or surgical correction of Pectus, are generally evaluated with either chest CT or, in some cases, optical 3D scanner. Almost all patients receive a stress echocardiogram, and some of these even can receive a cardiac MR. The surgical indication of these patients is based in general on the presence of at least two of these criteria, involving firstly and most importantly, severe malformations indexes, obviously, the presence of exercise-related symptoms, and significant either pulmonary and or cardiac manifestations. In our study, the data points collected were multiple and very diverse, and can be discriminated and summarized between those observed at rest, which were the presence of abnormal septal motion and general echocardiographic measurements, such as, for example, left atrium area, and those evaluated at rest and stress, both involving the assessment of systolic function, including left ventricular ejection function, TAPS for the systolic right ventricular systolic function, right ventricular systolic wave, compression of the tricuspid area, signs of diastolic dysfunction, evaluated both using transtricuspid and tisular EA ratio, also transtricuspid mean gradient, and the presence of or absence of a fixed tricuspid area at exercise. We also confronted all these findings to the chest malformation indexes, such as the Haller index and the correction index evaluated with the CT scan.
This is excellent. Many of us that are out in clinical radiology, clinical cardiology, don't necessarily have as robust a chest wall and chest surgical clinic as you have. So it's great to see what your approach is to the diagnostic workup for these patients. With regards to the results of your study, you show that there is a significant percentage of patients with pectus excavatum that demonstrate right ventricular dysfunction, much more so than in the control group that you recruited. Could you break down the results for us a bit more?
Yeah, findings were variable, and we identified several markers of diastolic and systolic dysfunction. Between other, we can mention that we identify abnormal septum motion in 64% of the cases, evidence of abnormal right ventricular diastolic function in 29%, including a 63% rate of EA inversion during stress, and evidence of systolic dysfunction in 16%, overall significantly lower S-wave, either S-wave or TAPSE, compared to the control group. Also, one finding that was very interesting was that the trans-tricuspid gradient was, although it was similar compared to the control group during rest, it was significantly increased during stress compared to the control, and in keeping with this, patients with Pectus show a fixed tricuspid area with inability to increase during stress. Actually, control cases show that a 37% of increase in the tricuspid area during stress, and basically among patients with Pectus, this was completely fixed with inability to increase during stress.
Excellent. And for those listeners that aren't as familiar with the metrics of right ventricular dysfunction, can you describe how severe this degree of dysfunction is identified in these patients?
Yeah, this is a very important issue, Praveen. I think we have to stress that both systolic and diastolic dysfunction in Pectus in these patients are typically mild. They are really mild. They are not severe. But also, it is important to mention that given the relatively common presence of exercise intolerance in these patients, it is likely that such mildings, since they are usually concurrent and diverse, there might be an underlying synergistic impact in this population. On the other hand, if this condition is left untreated, these patients can have obviously pulmonary alterations throughout their lives that will increase the demand of this already mildly impaired right ventricle. So in the experience of the center and the chest wall surgeons' experience, these patients are typically get some real benefit from intervention, just either conservative or surgical.
Very interesting. And did you perform any additional analysis to see which metrics were predictive of the patients that eventually needed surgery?
Yeah, we made after a median follow-up of 3.2 years, 33% of patients underwent surgery. This was just an ancillary analysis, but only younger age and the correction index were identified as independent predictors of surgery. And this was interesting because despite all the findings we identified, the identification of only age and correction index as the independent predictor of surgery might reflect the fact that even in centers very specialized in these pathological conditions, such as Fundación Hospitalaria, the decision to undergo surgery is still based on the severity of chest malformation.
Very interesting. One wonders if perhaps in the future, the surgical decision-making will incorporate some of what we learn about right ventricular dysfunction or cardiopulmonary dysfunction altogether. As we've been discussing, the etiology of exercise intolerance in these patients is likely multifactorial. What new insight does your study bring to this field?
Well, our study definitely do not offer any conclusive cause-effect relationships to explain the symptoms in this population. And it is unlikely, at least I think so, that future study will be able to demonstrate this, since the mechanisms involved in clinical symptoms are completely multifactorial. However, although the diastolic and systolic impairments observed were mild, we showed that these can be multiple and concurrent, including signs of impaired ventricular filling, signs of systolic function, abnormal septal motion, incremented tricuspid gradient, and even, in some cases, pericardial effusion. Also, we identified some additional interesting findings, such as small left atrium in these patients, low METs, and right bundle branch block, providing maybe unsophisticated means that might act as a surrogate of more complex findings. This might be interesting, I think, to explore in the future.
That's great. And that kind of brings me to the next point I wanted to ask you is, are you doing any work for future studies in this particular field, either of pectus deformities in general or in cardiopulmonary consequences of pectus specifically?
Yeah, as we discussed before, I mentioned maybe the last issue I told you is the way to go of our future research, to explore less sophisticated means that can evaluate the cardiopulmonary impact in these patients, such as optical 3D scanner, ECG markers, and 6-minute walk test, in order to make the assessment more available to a much wider population.
Excellent. Now, for those of us out there in clinical radiology, clinical cardiology, do you have any recommendations as to how to approach patients that our surgeons may bring to us that have these very complex pectus deformities?
I think that we should be very, we have to bring our attention to these patients, not only to the patients that come with pectus excavatum, but also I see many patients that come, for example, with palpitations, with arrhythmia, with indication of a cardiac MR, and actually the only finding they have is a pectus excavatum. So I think we have to train ourselves and our departments in terms of maybe each clinic, each institution can have develop expertise in some field, but some functional test needs to be done in these patients, either a stress echo, either a cardiac MR, either a 6-minute walk test, that in the future maybe, but also be aware that there are very subtle changes as some that we saw in this paper, such as, for instance, a small left atrium. Something such simple as a very small left atrium can bring us the attention that something is going on in these patients. And also we have to be very careful about interrogation in these patients. Interrogation in these patients, especially since they involve very young patients that have been living with this condition throughout their lives, can be completely subjective, and maybe we don't realize that these patients actually have exercise intolerance.
Excellent. Hey, Gaston, thank you so much for your time and expertise. Thank you very much for coming on to the podcast. This has been fantastic.
No, thank you so much, you, Praveen, and thanks to the journal.
Of course. This has been an extremely insightful look into your paper specifically and the impact of pectus and cardiac function in general. I encourage all of our listeners out there to get their hands on this paper that is available in the October-November issue of the Radiology Cardiothoracic Imaging Journal. And if you like what you hear on the podcast, please rate, review, and subscribe to us. Once again, my name is Praveen Ranganath, and this has been the Radiology Cardiothoracic Imaging Podcast. We will see you next time.